So we've talked so far about what each of the different controls does. We talked about mode, we talked about tidal volume, we talked about rate, we talked about oxygenation and how it's made up of PEEP and FiO2, and then we talked about the ID ratio. And that's most of the knobs that you'll see on the ventilator itself. There's some other ones that you might run across, but that's the basic stuff, at least to get started with. Now, how do you actually use that stuff if you're going to set up a vent? Somebody hands you a ventilator and hands you an intubated patient and says, go at it, put the patient on this thing. What do you do? Well, outside of making sure the thing's hooked up and you've got your oxygen supply line, you've got the circuit attached and all that kind of stuff, let's talk about just the faceplate itself. So you're handed the vent, you turn it on, and you start getting options to change things. If you're going to set a mode, I would suggest for most patients, this is folks that we don't think have bad COPD or bad asthma, but pretty much anybody else, whether they've got pneumonia, whether they've got a bad head injury, whether they're vomiting blood, whether they've got a CHF exacerbation. If I'm going to set it up for most people, I'd use about the following. So mode itself, if you don't know any better, pick a sys control with a volume setting. Because that's about the easiest and you know what it does and it provides the most support for the patient. We can kind of mess with it later. If you know differently and you're really adept at using the ventilator, okay, you can pick a different one, but that's what I would suggest for most of us in EMS who are not super familiar with modes of ventilation and don't have a good reason to do it otherwise. So AC volume, about that volume, we're going to pick a tidal volume of 6 to 8 mLs per kilogram ideal body weight. You can go ahead and pick 8 to start off with. So if they've got a 70 kilogram person, 7 times 8 is 56, add a 0 for the 70, and you end up with 560 mLs of tidal volume. And again, your tidal volume is going to be set based on the ideal body weight of the person. It's probably going to run for most Americans somewhere between 400 and 500, maybe 500 to 600 in an exceptionally large person, or in a significantly larger person anyway. If you're outside the 400 to 600 range, then you really need to go back and check your math again and make sure that you're doing this right, because most people are, again, going to fall somewhere in there, just as humans. Respiratory rate, we can go ahead and set at 15. 15 to 18, something like that. You need a few extra breaths per minute than if you were just breathing spontaneously, just because of the dead space in the vent and a little bit smaller tidal volume. So respiratory rate of 15 to 18 in most of these folks will get you started anyway, and then we're going to titrate that again to end-tidal CO2. For an IDE ratio, again, if you're a typical person and you have no other reason to do differently, then you could do 1 to 1.5 or 1 to 2 in your IDE ratio. And again, if you have somebody that has bad COPD or something like that, we'll talk about that in a minute. Then in terms of the oxygenation settings, PEEP and FiO2, I told you that if your FiO2 is 100% or 1.0, then I think that you probably need a PEEP up somewhere around 24, something like that, 20 to 24. That's in sort of best practices. However, that's not the way that I'm going to do it when I'm first setting up the ventilator. I'm going to set everybody with a PEEP of at least 5, because everybody needs at least a little bit of PEEP, if not maybe a little bit more than that, just because now they're getting positive pressure and they're sedated. So everybody needs at least a PEEP of 5 to start off with, and if they are on a PEEP of 12 or something like that, I'll go ahead and set that PEEP to 12, because if you put them on 5 and they were on 15, don't be surprised when their oxygen goes through the floor as a result. So either match whatever PEEP they're on or start them at least 5. And then when I'm initially starting somebody on a vent, I'm going to put them on an FiO2 of 100%, just to give them a little extra cushion in case something happens. The tube gets pulled out, the circuit becomes disconnected, we didn't have it hooked up to oxygen or something like that. I'm going to give them a little bit of extra cushion as much as I can by turning up their FiO2 to ward off any bad stuff happening. Pretty rapidly, I'm going to titrate that back down to 60%, 40%, something like that. Basically, as low as I can get it with a reasonable amount of PEEP accompanying it. And that's just sort of a little bit of a titration game, and you just kind of see how the patient goes. But after a couple of minutes, I'm going to go ahead and turn that thing down as soon as I'm sure that the patient's safely onto our ventilator. So that is basic ventilator settings for most people who have, they're getting intubated either for lung disease like CHF, or for ARDS, or for drowning, or for protection of their protection of their airway because they have a head injury. That works for pretty much everybody, except the folks with obstructive lung disease. And you may need to make some little tweaks in there, but that's pretty basic stuff that'll work pretty well for most people. The only difference is for the folks that have obstructive lung disease, we got to treat them a little bit differently because a regular vent setting has a good opportunity to hurt or even kill this person. To review one more time, obstructive lung disease like COPD or asthma, the big problem is that you can breathe in fairly well. Your diaphragm is pretty strong. It's able to suck in air pretty well. The problem with obstructive lung disease is that you can't breathe out because your little bronchioles and your airways, your small airways, have poor tone and they're sort of floppy and they just collapse once they get air inside them. Also, they're filled up with mucus, and so it's a big mess. So you can get air in, you could force air in, but the problem is getting air to go back out. That's the problem with obstructive lung disease. So we need to give them a little bit of time to breathe in, a quick breath in, but we need to give these folks a long time to breathe out. Lots and lots of time to do that, because if you try to force more air in on top of the air that's already there, eventually you're going to overpressurize and you're not going to be, either you're not going to be able to ventilate or you're going to cause a pneumothorax or at least get a pressure alarm on the vent and the vent will stop working. Keep in mind, too, that when you do this, putting these guys on a vent, putting somebody with obstructive lung disease on a ventilator doesn't fix the problem with their obstructive lung disease. Putting somebody with pneumonia or bad CHF on a vent may kind of help to fix that problem or at least temporize things for a couple of days. Putting somebody with bad obstructive lung disease on the vent doesn't really fix the problem. It just offloads their diaphragm, which is getting tired. So putting somebody on the ventilator with obstructive lung disease only gives you a little bit of extra time to make some big moves. And those big moves are usually bronchodilators, or if you're going to use magnesium, or if you're going to give them terbutaline, or whatever it is your next thing is to fix their asthma or to fix their COPD, whatever you need to do to fix that next, that still needs to continue to happen pretty quickly because you've only bought yourself a little bit of time and they can't stay that way forever. They just won't get better. So do give them albuterol, give them Xopenex, give them whatever your bronchodilator choice is, give them the IV medicines and the sub-Q medicines, do all that stuff after you get them on the ventilator. The ventilator is just giving you a little bit of time. So what are the actual settings we're going to do? Again, this is just obstructive lung disease. I'm still going to say put them on AC volume control for most of our people because it's relatively easy to set for most of our EMS providers. Set a tidal volume, same thing, somewhere between 6 and 8 mLs of ideal body weight. We're going to set, in this case, a respiratory rate that's pretty low. So before we set it at 15 to 18, in this case, you're going to set the respiratory rate at, say, 10 to 12, something like that. And why? Because we want to give them relatively long times to breathe out in between each breath. So if you're going at 20 times a minute, even though the patient may be trying to do that, they're not able to fully exhale. We want to give them a slow rate so they have plenty of time to get as much trapped air out as possible. And that is going to look a little bit weird. That's going to be a little different than you would do otherwise. And of note, this is for obstructive lung disease only, pretty much. You may think of a respiratory rate of 10 or a bagging rate of 10 when you're doing CPR, where you're giving slow little breaths every 6 seconds or something like that. Then yeah, that may be the other time we set somebody a respiratory rate of 10, but for the most part, if you put a respiratory rate of 10 on a patient that was otherwise breathing okay, you're probably going to cause them some problems. So in this case, we're going to set that slow rate and the other stuff that we're going to do specifically to let them breathe out more. And we're not going to do it on most of the other patients that we would see intubated or ventilated on a ventilator. So, slow respiratory rate, and then we're going to set our IDE ratio at something like 1 to 3, or 1 to 4, or 1 to 5, depending on how bad their COPD is, and there may not be a good way to know that. That, again, is going to give them a relatively quick breath in, and lots of time to breathe out. So, which may be necessary for somebody who's got bad COPD. Bad asthma also kind of falls in the same way. Give them lots of time to breathe out. So an IDE ratio 1 to 4, 1 to 5, something like that is not unreasonable, but at least 1 to 3 to start off with. And by the way, you may titrate that later on. The way that you would know that your IDE ratio is right, or that you're giving them enough time for it, or that you may need to change it, would be to actually watch the graphic as it comes across the screen. You watch the flow, and you make sure that flow goes back to zero, and pressure, everything goes back to zero before you get the next breath. If you don't have a graphic readout on your portable ventilator, on your EMS ventilator, the sort of poor man's way to do that may be to put your stethoscope on their chest, get it really quiet so you can really hear, and then listen for the wheezing to stop on their expiratory phase. If they're clearly getting a breath while they continue to wheeze, then they probably haven't completely emptied their lungs, and you may need to stretch out that IDE ratio. It's not, perfect. It's not 100%. It's not as sophisticated as the flow charts on the actual ventilators themselves, if you have it available, but most of us don't have that available. So it's something you can do if you have nothing else to use. So in terms of oxygenation, we do want these guys to get a lot of oxygen, again, to start off with, so go ahead and turn the FiO2 up relatively high to give them a cushion. The other thing you might wonder about is, well, what about PEEP? You just said their whole problem is that they can't breathe out very well. So shouldn't we put PEEP at like 0, because we don't want to cause any more obstruction. We don't want to cause any more difficulty breathing air out. So why wouldn't you set PEEP to 0? I'm going to still say you need to set PEEP at least 2, if not 5, and I'm going to go with 5 generally speaking. The reason for that is that if you think about these guys, if you think about the thing that actually collapses, it tends to be the small airways themselves as they're leading out of the alveolus. And if you put a little bit of PEEP behind it, not a ton, but a little bit of PEEP behind it, instead of letting that thing collapse and get stuck together with mucus, if you splint it open a little bit, then you actually improve gas exchange through that thing. So if you continue to keep those things open, you can have better gas exchange with it. So I'm going to put all these people at a PEEP of somewhere between 2 and 5, at least to start off with, and sort of evaluate till I know better. I don't think a 0 PEEP is a great idea in these folks. So at least 2, if not a little bit higher, and it will be a little bit beneficial for the patient. So we get it set. We put the thing on the patient, whether they've got a lung disease pattern like obstructive lung disease, or whether they've got fluid in their lungs or whatever it is. Get the ventilator set. And then the next thing you should probably do is put on the patient and let them sit for a little while. How long is a little while? Well, let's say 3 or 4 minutes, something like that. Because it's going to take a couple of minutes for your settings and for the way that the ventilator is working. It's going to take a minute to actually assess how comfortable that is. Much like when you put people on BiPAP or CPAP, when you initially throw that thing on there, they may be very intolerant of it, or it may be very uncomfortable. As things improve, as their lung segments open up, and as they start to get better gas exchange, people tend to feel better with it, but it takes a couple of minutes. Likewise, all the stuff like your CO2 measurements that you're going to be looking to titrate stuff with, that's not going to change instantaneously. It's going to take a couple of minutes to happen. It's going to take a couple of minutes just for blood to go from your lungs all the way out to your finger where your pulse ox is. So give it a couple of minutes to see how things actually go. Don't be in a huge hurry to make a whole lot of settings immediately after you put somebody on the vent. Let them sit. Likewise, after you make any changes, let them sit for a couple of minutes unless you got to do something life-saving. Like immediately, in order to prevent something terrible from happening. But give them a minute, or give them 3 minutes to actually equilibrate out and see how these vent settings are tolerated, and see how the vent's breathing with them, and then you can use that time as a little bit of meditative time to cognizate on what is going on with the patient and what sort of settings we might make otherwise. So to review all that stuff so far, what do we know so far? What have I talked about? Well, we're going to turn on the ventilator, and unless we have a good reason to do it otherwise, assist control with a volume setting is a great way to get started in terms of mode, and it makes things relatively easy and harder to screw up. Tidal volume, we're going to set somewhere between 6 and 8 mLs per kilogram of ideal body weight, and we're going to set that and leave that alone. We're not going to mess with that because this is the safety setting for the ventilator. This is the speed limit. We don't want it really doing a whole lot differently with that. We're going to set a rate for most people between 15 and 18. If they have terrible obstructive lung disease like COPD or asthma, then we're going to set it lower. 10 to 12 would be a good place to start. We're going to set our FiO2 initially as we're making the transition to 100% to make sure the patient's getting as much oxygen in case something happens, but then we're going to rapidly titrate that down as soon as we're stable on the vent to 60% or 40%, something low, trying to maintain a SpO2 of somewhere between 94 and 99%. You don't want it at 100, you don't want it at 85, but something in the middle there. If they have bad obstructive lung disease, we'll even let that kind of drift down to, upper 80s. If they have terrible COPD and they get ventilated and their SAT is 88%, that's actually not too awful bad. And it may take a lot of work to get it any better than that and potentially be dangerous. So start with an FI of 100 or 1.0 and then go down to about 40% or as close as you can get relatively quickly. Likewise, we're going to start the PEEP at 5 or match their current PEEP and then titrate up as the patient needs more oxygen in order to limit the FiO2 at the expense of giving them a little bit higher PEEP.